Hi, good afternoon, everybody. And I'm Dr. Kumar. I'll be presenting a talk on how to do sustainable treatment for non-traumatic orthopedic condition. So there are no disclosure. Well, my background is basically joint replacement and oncological orthopedic reconstruction and doing arthroscopy. But during my practice, during last 7 years, I used to come across these common conditions which are non-traumatic, like arthritis, inflammation of the tendon, muscle injury, ligament, and there are a lot of patients who are in the middle, who are not a candidate for surgery, and who are not getting any benefit from the painkiller or physiotherapy. So it's a frustrating for the patient as well as for the surgeon. So that's why I got help from Dr. William. He is here, and for last 5-6 years, we are into this regenerative medicine. It's an orthobiologic, and now currently my 50% of practice is in orthobiologic. So during this last 5 years, we also published few papers on stem cell and how they are helping in not only just orthopedic condition, also in COVID, on PRP, and also the autologous serum, which is one of the most promising treatment for arthritis, which is Goldic. So what is regenerative medicine? Actually, it's an upcoming branch, it's evolving, and it's a process of replacing or regenerating human cells and tissue by using your own things and to establish the normal function. So usually in adult, what happens, whenever there is any injury or degeneration, when it heals with a scar because there's not a lot of regenerative or remodeling potential. But when you bring the regenerative medicine into this, then it heals with either restoration of the function or helping or resetting the joints or the affected areas. Now, during regenerative medicine, there are a lot of challenges because you come across a lot of things like this is basic, sorry. Like if you search around like online or even in the media, in the magazine, that it's a miracle, it's a cure for everything, it can regenerate everything, and there are no side effects, and there is a lot of commercial product, and there is a lot of push on the doctors and on the patient for certain kind of product, and there are a lot of inexperienced practitioners. So these are the challenges which are making this branch to come up nicely, but still it's coming up. Now these are the main basically products which are available for orthobiologic. These are cells which are basically the stem cell. Then we have blood derived product which is mainly the PRP or autologous serum. Then the next step is either from the fat or from the bone marrow. From the pelvis you get the bone marrow, and then you have these condition serum. Prolotherapy is being available for last 60 years and it helps in many patients. So first we'll talk about the stem cell. It was the Kaplan who first described the stem cell. So what are actually the stem cell? These are unspecialized cells which can divide, increase in their number, and they can convert into other cell type. Like if you take a cell from your bone marrow, it can form into the fat cell, cartilage, or the bone. There are different kind of cell. Usually we classify them like an adult, which has a limited capacity. Everybody has in their body. Mostly they're available in the fat or in the bone marrow, and you have them in your intestinal lining. That's why every few weeks it is renewed. Same in the skin. Then you have embryonic stem cell, which are derived from the embryo during first 3 to 5 days. There is a greater capacity for self-renewal, and they are able to form all the cell type. And now the upcoming is the induced, where the adult cell can be reprogrammed to behave like embryonic stem cell. Now you can get it from your own body or you can get from the allogenic. The most common source from your own is the bone marrow or the adipose tissue. Now when you take from the fat, basically the biological treatment either is like a microfragmented adipose tissue, which means it's a mechanical basically separation. And when you use enzymes like collagen, you get the SVF, or it is the culture expanded. Now, if you compare from adipose, the stem cell from the fat in comparison to the bone marrow, usually these cells, the number, they don't change much with the age. They are more stable and they have a high proliferation and differentiation rate. The number of stem cells in the fat is 500 to 205 times than the equal amount of the stem cell when you take the sample from the bone marrow. So there is a nomenclature about which cell you can actually classify as a stem cell, and this is a standard classification. Now Kaplan basically revisited his concept because now it is said that these are not the stem cell. Basically these are stromal cells which are just helping and supporting the tissue. Kaplan did not agree with this. He said no, they may not be stem cell, but they are not stromal cells. And he basically coined a new term which is called medicinal signaling cell, that they are giving signals, certain growth factors and cytokines, so they should be called as medicinal signaling cell. We as propose that these should be called maintenance stem cell because they are initiating, promoting and maintaining basically a pro-healing environment. In osteoarthritis, we know the basic problem is the degeneration of the cartilage, and this is started by the innate immunity, which is basically the cells involved. The main cell is the macrophages and natural killer cells, and then it converts into a well-developed, established osteoarthritis. So there is an imbalance between a catabolic and anabolic. The catabolism is more, which lead to the degeneration of the cartilage. Now, if you want to understand actually how the stem cell work, there are different pieces of information you will get, but there's no comprehensive, concise piece. So we published this paper which look into basically how actually they are working. So there are two environments. One is pro-environment, which means healing. It's a anti-apoptotic, anti-inflammatory, anti-fibrotic and angiogenic. And the opposite of this is anti-environment. So what happens when you inject a stem cell? There is a series of response. The first response could be the first induction response, which means majority of the injected stem cell, they die. But before dying, they do their function by releasing growth factor and cytokines. These growth factor and cytokines then wake up the sleeping stem cell, which are called local resident stem cell. They supply growth factors and energy, and these local sleeping cells, they become active. In the second stage, this is called SIR, which means sustained induction response, which means during this phase, there are local resident stem cells who are more active, numbers are more, there is more energy, more pro-environment, and the healing is happening. But after some time, the signal, the support to the local resident stem cell, it wanes, and then it leads to the limited response, which is called limited induction response. So this is the way how it works. You inject the stem cell, first it is stimulated, then it sustained, and then the effect goes off. That's why you need repeated injection of the stem cell. So this basically hypothesis is a proposal to make you understand how the stem cell is working, but we need more study, more research to actually understand how they are working. Now, if we broadly classify how the stem cell work, they are basically anti-inflammatory. Whether it is degeneration, whether it is tendinosis, arthritis, there is some inflammation is happening, and they are promoting angiogenic healing and repair. And one of the main reasons for degeneration is immune-mediated injury, so they are acting as an immunosuppressive agent. In osteoarthritis, basically all these three mechanisms are working, so they are inhibiting conversion of M1 macrophage into M2. They're promoting basically the M1 to M2. M2 is the which promote the healing, and they're inhibiting the M1, which is inflammatory. Now again, they are working with immunosuppressive effect. Now if you see the literature, do the stem cell really working in osteoarthritis? It's conflicting, debatable. Most of the studies shows that it improves symptoms. So it improves the pain, range of motion, and the various score. We, as an orthopedic surgeon, we are using it, improve the score also. And the effect usually lasts for 6 to 12 months. But now some studies are saying it may last even up to 2 years or 3 years. But more randomized and well-controlled studies are required. What is the dose? There is a variable dose has been reported from 2 million cells to 1 billion. and few studies show that even if you use 2 million cell, it is as good as 1 billion cell. Route of administration are variable, but the most common route is intra-articular. Does there any effect on the X-ray? Most of the studies show that if you use a stem cell, there's no improvement in the X-ray. Only 1 or 2 studies shows that there is improvement, but you must have the same machine, same position, then only you can compare, and it should be a quantitative analysis, not just on plain X-ray or plain tomogram. What happens to the MRI? Same is with the MRI. Usually we see changes after 1 to 2 years. Usually the edema in the subchondral bone, it becomes less. The cartilage look more healthier. There may not be any increment in the thickness, although 1 or 2 studies show that it does improve the thickness of the cartilage. Are there any side effects? Well, most commonly after the injection, there is a pain and swelling which lasts for a few days and which needs simple like Panadol, some icing, and some immobilization for a short period. There are some serious complications, but they are not related to the MSC treatment. Usually, those who don't believe in the stem cell, they say it causes cancer, but the problem is not with the adult stem cell, and there are not any reported report that the adult stem cell causes cancer, but still there is theoretical risk because we need to have long-term follow-up. Then the next is the bone marrow concentrate. This we are using as an orthopedic surgeon for last decades, and now the technique has been refined. Now the bone marrow aspiration can be concentrated. There are various techniques, various kits in the market, and when you concentrate, actually you are reducing the number of the red cell, and you are increasing the number of the cells and the progenitor cells. The bone marrow this is how it looks like in the buffy coat. Now, there are various market preparation are there. We are also using basically the manual preparation. There are different techniques are available for that. If you compare the bone marrow concentrate with the PRP, the number of the growth factors, they are more in bone marrow concentrate. And of course, you have bone morpho, which is BMP protein, more in the bone marrow concentrate than in the PRP. Now there are new evidence is coming up. Usually after the injury, many of the time we see this subchondral edema. Before we used to treat it with just conservative treatment. Now evidence is coming that within 5 years, it leads to the loss of subchondral bone as well as the cartilage and leading to early osteoarthritis within 5 years. Now these are some of the cases which not only for degenerative but also other conditions like this is a trauma with intercondylar, and it was an open fracture fixed with the locking plate, but there was a lot of space was there. It was combined with the BMAC, PRP, and some of the allograft, and it healed nicely. Now, if we compare are there any evidence for the bone marrow? Yes, evidence is coming, but mostly it's like case studies or prospective studies. There are no well-randomized controlled trial, and they are showing that it does help in relieving the symptom in osteoarthritis, and we know there is a good evidence for non-union in fracture. This is another case. This is a adolescent who had this benign lesion which was interfering in his daily routine activity. So curettage bone grafting filled with PRP, BMAC, and he also had this Osgood-Schlatter syndrome which was also injected with the BMAC. And the patient improved clinically. This lesion healed in 1.5 years. Still the follow-up, the X-ray are required. I have only follow-up to few months. Now the next modality in orthobiologic is the PRP. It's a lot of interest currently in last few years. Actually, we know that before we were using the whole blood, then came the RBC, then came the platelet. Platelet, everybody knows what it is. Sorry. So in PRP, basically the number of platelet is above the baseline. The normal count is 150,000 to 350,000. There are various definitions. Either it should be 1 million or it should be above the baseline or 3 to 5 times. Platelet has a lot of growth factors and as well as 1100 proteins, more than 1,500 others bioactive factors. PRP is of two kinds. One is the leukocyte rich, where the leukocytes are there. Another is the leukocyte poor. Now PRP has lot of action. Some of them are theoretical, some of them they have been seen in practice. So it improves basically the synthesis of collagen 2, also help in the cartilage remodeling, also act as antimicrobial agent, and the most important thing, it help in homing, differentiation, and migration of the stem cell. Now, this I already discussed. There are now platelet has different granules. It is basically the alpha granules where most of the growth factors are present. Now the evidence is coming. Before we used to think in osteoarthritis problem is in the cartilage. Now we see that in subchondral level there is a crosstalk between the cartilage, and some of the research is coming. If you inject these biological agent in the subchondral bone, it will help and it improve the pain and function. We have also using the William and other surgeons, we have started using this, and it improves symptomatically, but X-ray wise we don't see any difference because it just started 2 years back. Maybe we need more follow-up, more cases. This is how we do. Just you drill it and then put a guide wire or a drill and then you inject the product. Usually we combine bone marrow and with PRP. If you compare the PRP with hyaluronic acid, the results are better with when you with the PRP in comparison to the hyaluronic acid. Now there is a meta-analysis that if you compare with the other modality, it improves the pain and function. Effect lasts for 6 months to 1 year, in some cases even up to 2 years. Now we are having evidence, and in our practice we are routinely combining the PRP with HA, and they have a synergistic action. Effect is better. The next is for the tendon, because we see a lot of tendon problem, particularly in sports. Over the time there is degeneration. So when there is a tendinopathy, there is a disorganized in the collagen. The cells are more, and sometimes you see calcification, sometimes you see the fatty infiltration. So we know that in the tendon we have also the stem cell and the progenitor cells, and it has been shown that the PRP, it induces more tenocytic differentiation, and it blocks the non-tenocyte differentiation. It increases also in the tendon-related gene and protein expression. Now, if you see the impact of PRP and the bone marrow, it enhances the proliferation of these progenitor cell. It prevents the chondrogenic differentiation, and it also prevents the osteogenic differentiation. Now, if you see the evidence, what is the evidence for PRP in tendinopathy? There is a level 1 evidence for lateral epicondylitis, also in osteoarthritis, early stages, and also patellar tendinopathy. Now the level in Achilles, particularly in the rotator cuff, is coming up. This was an old study, few years old, but still these are the three main areas, the tennis elbow, patellar tendinopathy, and osteoarthritis, which are showing promising result. Also some effect in the rotator cuff and tendo Achilles. Now if you see the systemic review, this is one of the systemic review, and it shows that the PRP, it reduces the pain in tennis elbow and the rotator cuff. This is another table. So this is basically the studies which are available to see how much is the effect, and it has shown that the level 1 evidence is there. It is effective for the tennis elbow. PRP is more effective when you use just the blood and more than the corticosteroid. There is no significant statistical difference between when you use rotator cuff in comparison to the PRP with the placebo. Now these are the references for the patellar tendinitis, and again it shows that the patellar tendinitis results, some studies show that it improves, some show there is no difference. This is a patient, 23-year-old, having the same, so ultrasound guided injection was done at the area of the pain, and there was a symptomatic improvement. Now the another modality which is coming, it's called Goldic. It's called gold-induced cytokines. It's basically a serum which is prepared from your own blood, and we take the blood in a special tube. It has gold particle. It's incubated for 24 hours in an incubator at 37 degrees centigrade. So gold particle is stimulate your cell. The next day you centrifuge and then you separate the serum. This serum is rich in cytokines. That's what's called gold-induced cytokines. And there are studies. Initially, it was published for horses in the tendo Achilles. Then it came for the animal in tendo Achilles. And recently, we published for the knee also. So it has been also used for the neck, for cervical and the lumbar disc. And it shows changes in the MRI, but this is happening only in some patient on MRI. But most of the patient, they have some improvement in around 70-80%. Effect is usually seen starting from 6 weeks. Full effect is seen in 3 to 4 months. We are also using here in Dubai for neck and the back. And this is for the PRP, for the pain, for the patellar tendinitis. Now this is for the tennis elbow. You can use ultrasound guidance, PRP. Results are better. If a patient has tried physio, steroid injection is not working, chronic condition, then this is one of the options before going for the surgery. So this is my talk, and this is my contact. If you have any question later on, you can email me, you can contact me. And if the chairman has any question from the floor, I will be more than happy to reply.
Thank you very much. I appreciate it.